Okay, thank you very much, Honorable Chairman. First of all, I address a very kind thank you for the invitation to participate of this Congress. I would like to thank the organizing committee and especially my friends Rosen Majev. Last but not the least, I would like to thank you for the opportunity to share my experience regarding the extended lymphadenectomy and proximal transverse colon cancer. As you know, the complete mesocolic excision with high vascular ligation have become a standard procedure in the treatment of colon cancer, regardless of the localization of the tumor, whether in the right and the left side of the colon. Taking into consideration that the transverse colon has certain embryological and anatomical particularities, with this presentation I will discuss the potential involvement of the gastrocolic lymph nodes in the transverse colon cancer. As I mentioned before, the transverse colon has several particularities. When discussing about the embryological ones, it originates from the midgut and hindgut. On the other hand, the gastrocolic ligament and great omentum have their origins from the mesogastrium and mesoduodenum during embryological development. Also, these structures may appear separate. They are closely interconnected. Understand this relationship is essential for correctly identify the planes during dissection. In 2008, Werner Hohenberger introduced the principle of complete mesocolic excision in colon cancer, which involves dissection among embryological planes through mesophacial separation, allowing and block lymphatic, vascular, and perineural tissue resection with intact mesentery envelope. In addition to complete mesocolic excision, a central vascular ligation is performed, which allows apical lymph nodes removal. Furthermore, the concept includes an adequate length of colonic resection. Several studies have demonstrated a close anatomical and embryological relationship between the transverse colon and the great omentum, and Stelzner performed a microscopic dissection study in human cadavers and discovered the small bowel and lymphatic vessel crossed the embryological interface connecting the great omentum with the bowel wall. On the other hand, the Japanese Society for Cancer of the Colon and Rectum has demonstrated the importance of T2 or D3 lymphadenectomy in colon cancer, with dissection being performed in an axial plane up to the roots of the mesentery. This is an image. And what should we do when the tumor is located in the proximal part of the transverse colon? Is the strategy change? Is axial dissection sufficient, or is an horizontal extension of the dissection is necessary? The dissection must include the gastrocolic ligament lymph nodes, and the transection should be performed as close to the stomach as possible. The incidence of gastrocolic lymph nodes metastases were found up till 9%. What does this mean? Is it high or low incidence? If we consider that the incidence of the central lymph nodes metastasis at the root of the mesentery is only 3 to 5%, like you had to show, during a D2 or D3 lymphadenectomy, an 8 to 10% rate of incidence seems very high. A higher incidence of gastrocolic node dissection metastasis was especially found in a patient with T3 and T4A stages, or patients who present obstruction, lymphovascular invasion, and the sign ring adenocarcinoma. Parakis also demonstrated that during surgery for transverse colon cancer should include the gastrocoli ligament with corresponding lymph nodes number 204, 206, and 214, like a gastroepiploic vessel, infrapancreatic or infrapyloric zone, and anterior surface of the pancreas. In this situation, the length of the resection gastroepiploic artery should be adapted to the tumor location and should surpass with 10 centimeter proximal and distant for the tumoral margin, what you see here in this slide. The studies and even our personal experience did not show an increase of the morbidity or mortality rates during the complete mesocosic excision with central vascular ligation and gastrocolic lymph node dissection, such as lymph leakage, bleeding, acute pancreatitis, or delayed gastric empty, although it's increased only the operative time. In our study, we found an involvement of the gastrocolic lymph nodes in 11.6% cases, showing a higher rate than the studies. The metastases were found especially in T3 and T4A stages in accordance with the literature, and especially all the tumor is high-grade or low-grade dysplasia. It is very important to make a good dissection, to respect all the rules of the CME, and I must make a very good sharp dissection. And we have a few intraoperative image which show an intact envelope of the peritoneum in order to maximize the lymph nodes removal to prevent the tumor spillage and to avoid transgenomic spread of cancer cells during surgery. In the first picture, the marked area is represented by the future resection area. And the second shows the final aspect after the gastroepiploic arcade resection with CME, with central vascular ligation, and D2, D3 lymphadenectomy. What you see here, it is the main dissection plate to the superior mesenteric vein, entire the face of the pancreas is and duodenum, and show it is the greater curvature without lymph nodes and fatty tissue. We mark the lymph nodes identified in a gastroepiploic arcade to easier to find the anatomopathologist. And the second one we show the origin of gastroepiploic vessel and 2.6 lymph node station to the inferior border here, the superior border of the pancreas, infrapyloric nodes. And now I prefer to show the images from open surgery, open approach. Why? To understand better anatomy, to understand the plane when the dissection, and show to different technical aspect. It's more easier to understand, especially in the young surgeon. And the second image, we have the specimen before the resection. We content the whole integrity of peritoneal envelope with gastrocolic ligament and great omentum. This is a new image for the D3 dissection. We see the main axial plane for the resection to respect all the CME and CVLE rules. The entire pancreas border and an inferior border, you see the superior mesenteric artery, and the specimen with mark with notes for the gastrocolic ligament. In conclusion, complete mesocolic excision with central vascular ligation and gastrocolic lymph node dissection implies knowledge of the anatomy and surgical team experience in oncological surgery. Excessive lymph node dissection with adjuvant chemotherapy can reduce the recurrence and metastasis, improving the outcomes and sure the overall survival. Therefore, the gastrocolic lymph node dissection should become a standard in the presence of the transverse colon cancer in advanced tumor. Thank you very much for your attention. Blagodaria.